All right, and welcome to mini session number 10 for the abdomen projections. Okay, buckle up. So now this one's going to get heavy. The projections, here's the outlines. It's on canvas. And I know it looks like a lot, but if we just break it up into little sections and go, you've already learned most of this. Um, so the SID for the abdomens is going to be 40 inches. You're going to use a grid because it's bigger than the thickness of your hand. The KVP range, we've been talking about that, is between 70 and 85. Okay, so you already know those. Yay! We're going to talk about the KUB, which we've talked about before. This is the actual words that is going to be used in the test. So the position of the patient has to be supine with the mid-sagittal plane centered towards the midline of the table or the IR. If your patient is on the table properly, then everything should be fine. The arms should be placed at the patient's side, away from the body, and bend the knees to support the back. The part position, let me fix that. Center to the level of the iliac crests, with the bottom margin at the pubis symphysis. Now, we've been talking a lot, and you have to be aware that you may have to do two projections, a landscape high and a landscape low, on people who may be a little bit bigger. The central ray, that's what CR stands for. The central ray should be perpendicular to and directed to the center of the IR at the level of the iliac crest. Collimation needs to be open to all anatomy, including the skin, so don't cut off on the borders, and make the exposure at the end of respiration. So we have a whole evaluation criteria that we go through. For a KUB, we have to see the outline of the liver, the spleen, the kidneys, the psoas muscles, and the air-filled stomach and bowel segments, as well as the arch of the symphysis pubis for the bladder region. There should be no rotation. The iliac wings, which is the pelvis, needs to be centered both together. The obturator foramina and the ischial spines are symmetric. The lower rib margins are the same distance from the spine, because when you turn like this, they will elongate, and the patient shouldn't look tilted. So there shouldn't be any motion. All the ribs and the gas bubbles should appear sharp. Sufficient exposure factors for KVP and MAS to visualize the psoas muscles, the lumbar transverse processes, and the ribs. The margins of the liver and the kidneys should be visible on smaller to average sized patients. So let's go take a look at this now that I talked about it. Boop. The routine projections for an abdomen: AP abdomen, AP upright or erect abdomen, and a PA chest. There's special projections of a dorsal decubitus, a lateral decubitus, and a PA prone. So this is the AP spine. That's literally everything I just went over, but here it is on a slide. If you want, you could print out the slide, shrink it to the size of an index card. It might be too big, not sure. But anyways, here's looking at an AP supine abdomen. It is centered directly to the middle of the bucky. He is got this line on the mid-sagittal plane, and there is your CR right there. You can see his iliac crest. It's right there. So here we should be able to see, well, that's actually a kind of grubby image, but we have the symphysis pubis. Actually, I would not pass that film. And there's no diaphragm on here, so we would have to retake for a diaphragm image. All abdomens need to include a diaphragm. So I picked a bad image. Haha. Moving on in the outline. So I essentially just copied the outline to the slides. You can read it however you want. The next one is going to be the AP projection, which is the upright or the erect position for the abdomen. So this is where your patient is standing. And if your patient cannot stand, then we have other ways of doing it. But the patient should be upright with their legs slightly apart and their back up against the buckyboard. Now, first things first, perform the upright abdomen image if the patient was already brought down upright. If they were in a wheelchair, if they were walking, just go ahead and do the upright, because otherwise you're going to lay them down. Then they have to wait another 5 minutes for the air to come back up. So go ahead and do the upright first if that's how they came to you. Make sure the body of the center of the body is centered to the back of the bucky. I know that may be hard to do, but you'll be able to see the back line on the bucky and line it up with their spine. Okay. Patients, if they're coming up for you to have an erect abdomen, they may have a big abdomen, they may have just had surgery, may have an NG tube in, and you won't be able to see anything on their abdomen. You can touch the top of the iliac crest, but that may not give you a good determination of where you need to be. So I always just take the back of the neck and line it up with the black line on the buckyboard. It must include the upper abdomen. So I think it's always just safe to say if you get a 3-view projection for your abdomen, do the chest, turn them around, bring it down just a little bit, do the abdomen because you already saw the diaphragm on the chest. Bring it down a little bit, don't cut off the diaphragm, just about 2-3 inches. Do the upright, and then do the supine. Okay. So, oh no, for the evaluation criteria, and this has to be exposed at the end of expiration as well, the evaluation criteria is an air-filled stomach and loops of bowel and air fluid levels where they need to be present. It should include both diaphragms and as much of the lower abdomen as possible. Small intraperitoneal air is present. Whatever, we'll get into that here in just a second with the critique and the clinical indications. I'll show you what air looks like. So there shouldn't be any motion, all the ribs and gas bubbles sharp. And they also say to go up and I'm just going to tell you on the mass for an upright abdomen, you're going to go up quite a bit because all that fluid has nowhere to go, and you're going to have to shoot through that fluid a whole lot more. So the kVp range is still good, but just be aware that they'll say, oh, you've got to up your technique. And you're like, why? It has to do with the fluid and the motion of the fluid. So here's what an upright abdomen looks like. You can see here is the crest, and they moved up a couple inches. Because if he just did his chest, which, no, I didn't put it on here. We've already learned PA chest. If he did his PA chest, all he had to do was turn around. They just bring it down and do the abdomen. So oh no. So right here you can see, I didn't put it on slideshow. I'm so sorry. There we go. So laser pointer. So right here you can see both hemodiaphragms. Here's the left side and here's the right side. You can see gas bubbles, which are the black. Here's the gas bubble in the fundus of the stomach. And you have air fluid levels. All right, you see where it's making a sharp line right there, right there, right there, right there, and right there. That means that there is fluid in the abdomen or inside the small intestine that's creating an air fluid level. Just like how you have the bubble of your fundus of your stomach here, and it's got a air fluid level, that's what's creating this. Okay, so Get it, go. Go. There we go. So I've never, ever done a PA prone abdomen. It's essentially the same thing, just your patient's laying on their stomach. No motion, no rotation. They still have to breathe out. And that's when you make the exposure. And here's what it looks like. So a lateral decubitus. Everything is still the same. 40 with a grid, 70 and 85. Now this is where it gets a little tricky. The lateral recumbent position requires that a patient be on a radiolucent pad. I'm going to switch it over so that we can see that. There's a pad right up under there, up under her. That pad raises the abdomen up off of the table so that we could take a picture. So the actual IR plate for this image is on her left side. If I could get this thing to go, that'd be cool. Oh, and the grid device has to be locked so it doesn't run away. And let's see. Oh, okay, there we are. Adjust the patient and the cart so that the center of the IR and the central ray are approximately 2 inches above the level of the iliac crests. So we need to include the diaphragm on this. So you can see her iliac crest. Well, we'll move over here. This is going to be a horizontal beam centered directly to the center of the IR, 2 inches above the crest. So what we should be able to see is air-filled stomach and loops of bowel if and when they're present. And it should also include the bilateral diaphragm. There should be no motion, no rotation, any of that good jazz. How is it I can turn a thing, but then it doesn't want to go? There we go. So here we are. This is centered about 2 inches above her crest, and it's going in at a horizontal beam. All right. So this looks like we could have her on the bed and put it up against the wall, Becky. There's your little left marker, denoting that that's the left side. So on this, let me just show you. So here's the wings of her pelvis. That looks pretty good. You can tell she's straight on because her L-spine looks like little marshmallows until you start seeing you see the flat side of it here. And right here is the costophrenic angles. Here's some bowel, here's some bowel, and here's some bowel. See, that's a pretty good image. So here's a lateral abdomen position. Do it on the table, same as before, 40 inches grid, range is 70 to 85. You just have the patient turn onto one side or the other. The elbow's got to be flexed up, arms up, knees up. And let's see, we're aligning the mid-coronal plane with the midline of the table. The patient still has to take a deep breath and blow it all the way out. So the evaluation criteria is the diaphragm in as much of the lower abdomen as possible should be included. No rotation, as evident by superimposition of the posterior ribs and posterior borders of the iliac wings and bilateral ASIS. So this is what they're talking about. Let's get my little pointer. So the central ray is going here. And that is pretty much the level of right here. So if this person was rotated, you would see the spine rotate out this way, okay? These ribs wouldn't be aligned nice and pretty, and this part right here would also flop over to the side. Okay, so that is pretty much all the positioning on the abdomen. Yay!